In this lecture, we're going to begin looking at the processes then that will alter the glomerular filtrate that makes its way into the nephron tube and create the finished product, the urine that is going to get rid of all the stuff that we need to get rid of from the body. So there are three processes at work when we make urine. The first is glomerular filtration. So this is where blood pressure will force the plasma of the blood out into the glomerular capsule, and we squeeze out at all of the 1.25 million glomeruli per kidney. We squeeze out across all those glomeruli about 180 liters of water every day. That's something on the order of 45 gallons. That's a whole lot. And we reclaim, we reabsorb, we pull back into the body approximately 99% of all of that plasma, the fluid that that we have filtered from the blood. And we pull that back in through a process known as tubular reabsorption. So with tubular reabsorption, the nephron tubule will selectively choose some components of the filtrate to call back into the body, to bring back in, because we don't want to get rid of these things. So it's easy to get confused on the exam. A lot of students go wrong here by forgetting which way each of these processes is moving materials. Glomerular filtration moves materials out of the blood, while tubular reabsorption will draw materials into the fluids around the nephron tubule, and eventually those materials will make it back into the blood as well. So some of the things that we selectively reabsorb include water and electrolytes, especially sodium, glucose that may have squeezed out, and we reabsorb those things while leaving all of the wastes that we don't want to keep in the body, leaving those in the tubular fluid. Then the third process is known as tubular secretion, and this is where we can pump into our urine additional wastes, let's say hydrogen ions, because we have become too acidic. Our blood and body fluids have become acidic, so we can secrete into the developing urine hydrogen ions or toxins and pharmaceuticals that the body doesn't want to keep inside of the body fluids. So what we talk about or think of as our urinary output each day is the process of everything that we filter out of the blood into the tubule, plus everything that we secrete into the developing urine, minus all of the good stuff that we reabsorb back into the body. That's what our urinary output is. And so through the processes of glomerular filtration, I'm having some difficulty here with my little setup. Okay, let's see if we can get things organized there. That's better. Okay, so through the processes of glomerular filtration, which puts everything, 145 gallons of blood plasma gets squeezed out every day. So that puts stuff out into the urine, and tubular secretion, where we get rid of additional toxins, minus all the stuff that we call back into the body, all the water, the electrolytes, the glucose, everything that we don't want to lose. That's what our urine is. So be sure to keep in mind that when we do tubular reabsorption, we're calling things, we're reabsorbing it back into the body, while tubular secretion is busy putting more stuff into the developing urine. Okay, so let's look at how glomerular filtration works. Filtration is a passive process. It's blood pressure. There's no ATP required here at the kidney to do glomerular filtration. It's just pressure pushing fluids and all this dissolved stuff through these holes that we see in the capillaries, and then on through the fenestrine between the podocytes. So with the work of the blood pressure pushing out through the holes and then on out through the fenestry, we create glomerular filtrate. And again, it's the fenestry that prevent the plasma proteins from escaping through these especially large pores through the wall of the capillary. So all those plasma proteins that we talked about back in the blood chapter, we keep all that remains in the blood, because assuming that we have a healthy kidney here, because the fenestry prevent it from escaping out of the glomerulus. So along with the water that is squeezed out as filtrate, waste materials like urea is the waste that we make as we process and metabolize proteins. Uric acid is the waste that we make as we process and metabolize nucleic acids like DNA and RNA. Glucose, creatine, and creatinine. Creatinine is these are wastes that are produced in muscle contractions. And then lots of ions like sodium and chloride ion and potassium, the bicarbonate ion, phosphate ions, sulfate ions, and whatever other small dissolved particles there are in the blood will pass out of the capillaries through the holes, through the fenestry, and into the glomerular capsule. What remains in the blood is red blood cells, most of the plasma proteins, and enough water to keep the blood flowing. So we wind up squeezing out something on the order of like 20% of blood volume is lost here at the glomerulus in the form of glomerular filtration. So filtration pressure then, hopefully you've realized this already, filtration pressure is very important because it is what causes it's the pressure that pushes the fluids out of the capillaries. So how do we maintain high filtration pressure even though we're losing 20% of the blood? Well, if you look back at pictures in your book, I should have had a picture on this slide, I'll have to think about that. There's the Efferent Arteriole, and then there's the glomerulus, that knot of capillaries, and then there's a much smaller efferent capillary that leaves the glomerulus. So because we bring a lot of blood into the glomerulus, but we only allow a little bit out, this creates high pressure here at the glomerulus that causes lots and lots of hydrostatic pressure that pushes fluid out of the glomerular capillaries. So because of this, this is a little bit like sending a whole bunch of traffic into downtown and then not letting, like having 5 streets coming in and only 1 street going out. That's going to create a little bit of backup in the downtown area in the glomerulus here. And so that helps to increase blood pressure. So we get lots and lots of hydrostatic pressure that pushes fluid out of the glomerulus. But there are some forces that oppose this push out. The first is the colloid osmotic pressure of the blood. And we've talked about this a lot. Unfortunately, all I have is red here. But if we think about all those blood plasma proteins that are found in the blood that give it colloid osmotic pressure, that opposes the push out. So it creates a draw in. So we get water, there's a water pressure that would call in water from the developing filtrate. So because glomerular hydrostatic pressure is much larger than the colloid osmotic pressure of the blood, fluid still leaves. And as fluid leaves, because it's captured in kind of a closed, sealed up cavity here, there is a drain that leaves it, the proximal convoluted tubule leaves it, but there can still be capsular hydrostatic pressure. So as fluid builds up outside of the glomerulus, that creates hydrostatic pressure that pushes back into the glomerulus. So between the colloid osmotic pressure and the capsular hydrostatic pressure, there is a, it's not an inconsequential amount of pressure calling fluid back into the blood. But as long as there is more hydrostatic pressure, more blood pressure inside of the capillaries of the glomerulus, then there is colloid osmotic pressure and capsular hydrostatic pressure, then we're going to push fluid out. So the net filtration pressure, the overall filtration pressure out of the glomerular capillaries is this equation. The glomerular blood pressure less whatever the colloid osmotic pressure is, less the capsular hydrostatic pressure that would be also pushing fluid back into the blood. So that is the net, or the overall filtration pressure out of the glomerulus. All right. So the rate then of fluid moving out of the glomerulus is directly proportional to the net filtration pressure. The greater the net filtration pressure is, then the greater the filtration, the greater the amount of filtrate that is produced. So blood pressure is usually the most important factor in maintaining an appropriate glomerular filtration rate, because blood pressure exceeds the colloid osmotic pressure, and that will increase. As we lose more fluid, then we're going to only increase the colloid osmotic pressure of the blood. So there are some other factors, though, that can affect glomerular filtration rate. For instance, if colloid osmotic pressure decreases, so if the draw back into the blood is less, then we will increase glomerular filtration rate. As well, if we were to increase this capsular hydrostatic pressure, let's say here's the glomerulus, here's the proximal convoluted tubule, and there was, say, a kidney stone that developed, that would create hydrostatic pressure pushing fluid back toward the capillary networks. So if we increase hydrostatic pressure of the capsule, then that's going to decrease glomerular filtration rate. So a decrease in colloid osmotic pressure will provide an overall increase in glomerular filtration rate, while an increase in capsular hydrostatic pressure will provide an overall decrease in glomerular filtration rate. Okay, hopefully that made sense to you. Of course, as always, if it doesn't, then let me know. Send me an email and I can work on trying to explain it differently. So, how do we regulate glomerular filtration rate then? Well, we maintain filtration rate through sympathetic control and reflexive control and reflexes of the smooth muscle and blood vessels. So if there's an overall decrease in blood pressure, then that's going to decrease the pressure of squeezing urine or developing urine out of the blood plasma. So in order to maintain appropriate blood pressure at the glomerulus, we see constriction of the afferent and the efferent arterioles. Both of them must constrict. If we just constrict the afferent arteriole, the incoming blood pressure, then we are going to see a decrease in blood pressure, because blood will keep flowing out at the usual rate and we'll just be sending it in at a lower rate. Whereas by constricting both the incoming and the outgoing, then we can create an overall increase in blood pressure here at the glomerulus. So having local control, if we have a little bit of a drop in blood pressure, no big deal. The afferent and the efferent arteriole will both auto-constrict, and we will maintain blood pressure so that the glomerulus will be producing enough glomerular filtrate. we also control this blood pressure through what is referred to as the Renin-Angiotensin system. So if there's a decrease in blood pressure, and this is going to be affecting or done by work at the juxtaglomerular apparatus that we talked about in the last video. So if there's a decrease in blood pressure, it's going to be noticed by renal baroreceptors. So these are pressure-sensitive cells that notice it, and they're going to cause the production of the enzyme renin from the juxtaglomerular cells. So this is from the juxtaglomerular cells. Remember, there are two sets of cells there, the juxtaglomerular apparatus. If there's a decrease in the amount of sodium that's found in the blood, or in potassium and chloride ions, so if we see a decrease in electrolytes, then the macula densa cells are also going to secrete renin. And we've already talked about this a little bit because we know that the effect of renin then causes aldosterone to be secreted. But that's not the only effect that renin has. Renin will act on a blood plasma protein called angiotensin. Renin acts as an enzyme that will convert angiotensin into a slightly different protein called angiotensin 1. So this is our first step, is that we convert angiotensin, which is found in the blood all the time, into angiotensin 1 because of the effects of renin. Angiotensin 1 will then be circulating in the blood. And when angiotensin 1 makes it to the lungs, then there is, on the inner surface of the lung capillaries, an enzyme called angiotensin converting enzyme, or ACE. So this angiotensin converting enzyme then will take the angiotensin that's floating past in the blood and will again modify that. It acts as an enzyme and it modifies the angiotensin 1 into angiotensin 2. We say, well, so what? What does that mean? Well, these are the effects of angiotensin 2. We see vasoconstriction, we see increases in aldosterone secretion, and we see increased antidiuretic hormone secretion. We haven't talked about that one yet, but as you might guess, antidiuretic means it's stopping you from peeing a big volume of fluid out. It's going to conserve water in the body. And we'll see increased thirst. All of these have the effect of increasing blood pressure. So vasoconstriction, we know that that will increase blood pressure. Because we increase aldosterone secretion, aldosterone will help us to conserve sodium while getting rid of potassium. We save sodium, that keeps water in the body too, up goes blood pressure. Antidiuretic hormone prevents us from peeing water out, up goes blood pressure, or at least we maintain blood pressure thanks to that. Increased thirst means more drinking, more fluid in the body, and again, an increase in blood pressure. So all of the effects of angiotensin 2 are to help increase blood pressure. So we see all these effects. Last of all, if the blood, or if the heart notices that blood volume is increasing, then we produce something called atrial, because it's happening near the atria, natriuretic peptide. Natri, that means sodium, Na+. Natrium is the old school term for sodium. Uretic, that's like uresis. This means pee away. Well, maybe not exactly or directly means pee away, but you get the idea. So we're going to pee away sodium ions. If you pee away sodium ions, what else will you pee away? Hopefully you said water. So atrial natriuretic peptide notices an increase in blood volume, causes us to pee out sodium ions. Because we're peeing out sodium ions, a lot of water goes along with it. And so this will decrease blood volume in the face of decreasing or increasing blood volume. And all of this occurs because we increase glomerular filtration rate. So GFR, as we're squeezing out more sodium, we're also increasing the overall glomerular filtration rate.